Hi, I'm Dr. Matson. Today we're covering Chapter 21, following the Open Stacks textbook, Population Health for Nurses. We're going to be focusing on cultural influences on health beliefs and practices. So just as an overview, what we're going to cover is race, ethnicity, culture, and nationality, cultural groups and formation of a cultural identity, the role of culture in shaping health beliefs and practices. We're going to look at cultural views and practices and looking about how culture matters and how we can address health inequities. So your goals, what you should be able to do by the end of this lecture: describe racial and ethnic makeup in the United States, explain the concept of diversity, be able to look at groups and diversity calculations, and then discuss ways in which race and ethnicity describe diversity and differentiate between race, ethnicity, culture, and nationality. So the difference between race and ethnicity. So what we're going to talk about is that they're distinct but interconnected. So when we think about race, this is a societal construct commonly defined by physical characteristics such as bone structure, skin, hair, or eye color. It's also based on social factors and cultural backgrounds. Race is assigned, so rather than inherent or chosen. When we think about ethnicity, this is a fluid concept. It's rooted in shared cultural traits like language, religion, nationality, history, or other cultural factors that bind people and groups together. For culture, there's no single definition. It's universal, it's personal, but it does have a huge influence on what a person values and how they respond to work, education, stress, health. And then nationality, this is really describing an individual's citizenship. So what country? So in the United States, the demographic has changed dramatically in the last 100 years. So statistically, we've seen a 276% growth in people identifying as two or more races. So this in part can be people coming over to the United States. Also can be people saying more races on the surveys that are happening. In 2021, the United States was more diverse. In 2010, with Hispanic and Latino populations growing the most, up to 18.9%. And conversely, white non-Hispanic Latino populations decreased by 4.5%. And diversity, when we're thinking about that, that's the relative size and representation of these different racial and ethnic groups within the U.S. Census Bureau. So, and you can see when you go into that U.S. Census Bureau, you can toggle between this and then look at things like specific diseases, cancers, heart disease. You can look at education, income. So that's where we're able to make these distinctions and then look at the statistic differences there and how we want to think about how that impacts health. So that U.S. Census category, it's Hispanic Latino, white alone, non-Hispanic Latino, Black or African American alone, non-Hispanic Latino, American Indian and Alaska Native alone, non-Hispanic Latino, Asian alone, non-Hispanic Latino, Native Hawaiian or other Pacific Islander alone, again, non-Hispanic Latino, and then some other races alone, and then multi-race. So the U.S. is heterogeneous. The society is filled with people from various ethnicity, cultures, and religion. And when we think about how this is really important, it impacts, again, that access to how do people have access to health care, how do they interpret their health, health literacy, education, income, where people are living. So we're going to start breaking it down. So multiculturalism, this is coexistence of diverse religious, ethnic, or cultural groups in society. they're all adhering to the same rules. Cultural pluralism is one dominant group in society in which minority groups participate fully. The United States has a dominant culture, and it allows minority groups to maintain their unique identities within that larger society. We have seen this changing, and it does impact policy, education, and that can create system challenges. So when we're looking at race, ethnicity, culture, and nationality between 2010 and 2021, the Hispanic Latino population grew the most. Again, we said this increased from 2.5% up to 18.9%. And this is just showing here that what we talked about, where the white non-Hispanic Latino population had the most significant decrease, dropping about 4.5%. Now we're going to talk about culture, non-material, material culture, cultural traits, visible and invisible elements of culture, and collective and individual traits. So a cultural group, this is sharing a core set of belief patterns, behaviors, and values. When we think of subculture, this is known as an aggregate. So this is sharing distinguishing characteristics that is identifying with a larger parent culture. So cultural patterns of behavior are acquired, not inherited, and they're learned through this process of enculturation. So a culture shares a particular set of traits. This can be material, so objects, places, or it could be non-material, like ideas and values. When we think about this, there are a lot of hidden elements there, and it really influences how people are socialized and interact with one another. And when we think of this individualistic culture, this is encouraging independence and separation from others. Collectivists look at this interdependence and interest as a collective whole. When we think about this in terms of community health, we need to see where this is happening and really understand the population that we're serving in order to have really impactful health education or programs that are going to bridge the gap between health promotion and disease prevention and discharge planning and continuum of care. So one image that's commonly described as this iceberg, right? And so it's saying this cultural group is this formation of this iceberg, but within that there are things that we can see. So art, dress, food, language, literature, and then what we can't see could be things like ethics, competition versus cooperation, time, how people value time, handling emotion, communication style, beliefs, notions of modesty. These are all things that are not always as apparent. When we think of identity in a culture and how a person identifies by a cultural group in society, we can think of things like food, tradition, clothing, how things are celebrated, so holidays, religion, which is very vital in many cultures and impacts how people partake in their health belief, and we need to understand that as a nurse. Social organization, this is the influence of culture. We can think of power structures, so who has an authority and is that impacting cultural practices? And we think of social hierarchies, so whether or not a group is organized in rank can also impact practice. We look at economic systems. Where are the resources? Where are they distributed? Are they in one area? Are they throughout? And same thing with education and attitudes towards education. Do people feel like it's just a box to be checked off? Or is their culture something where they value the knowledge? And so we can see how culture really is impacting how people even approach education. Now we're going to talk about how culture impacts health. So, the World Health Organization introduced this modern understanding of health in 1948, and it was described as a state of complete physical, mental, and social well being, and not merely the absence of disease or infirmity. So, if we think about these historical views of health and informing health related belief systems, we can look at the Greek view, which looked at this harmony between individual and their surroundings. Look at an East Asian view, which looked at health as a unity of body, mind, and spirit. Native American views perceived that physical health were connected to spiritual health. When we think about the writings of Plato, Aristotle, Hippocrates, these influence beliefs that many societies adopted and adapted throughout centuries, right? So Plato, this was the idea that health is this internal harmony with physical and social environment. Aristotle looked at health in terms of qualities: hot, cold, wet, dry, and it really characterized the elements. So people's belief about health and health illnesses, this really varied depending on cultural factors. When we look at the cultural environment, this is defined as social, economic, and political and historical factors that experience and influence our belief systems. So things like institutional structures, family dynamics, religious institutions, and political systems. So we can think of this on really like 4 different levels. So microsystem, what is that immediate impact of culture? A mesosystem, which is looking at interactions between these microsystems, social organizations, and then we can look at an exosystem, so external systems and institutions, and a macro system, so this broader social context. The chronosystem level refers to an influence of time and history on an individual's cultural experiences. So here we're just looking at a picture just for us to reflect a little bit on Thanksgiving dinner, right? So people gathering around, and this is a community of different people all sharing within kind of a larger cultural ritual. When we think of culture, it really impacts how we perceive death and dying. So what is the belief in regarding death, mourning, and afterlife? And this impacts how people cope with something like a terminal disease or chronic illness, how they cope with stress. And there have been cultures that use spiritual practice to meditate, right? So they're thinking of that as stress relief. We think of the Catholic culture and the rites of dying. So someone is dying, they have a priest come in and they get blast rate. And so are these things happening that help people handle stress? And how, as nurses, can we understand these different cultural aspects and then from there support them in order to help really bridge that gap within culture? So we're thinking of also how people, perceive and report illnesses. So are they going to report a symptom, or do they not want to report a symptom because of how that impacts their culture, right? And then pain and discomfort. So many cultures have beliefs that shape experience of pain and discomfort. They may downplay or minimize symptoms, and others may be encouraged to be very vocal about it, right? So we don't want to stereotype or categorize people, but instead accept them and support them and be able to plan care and education around, and not only around the culture actually, but adopting it into how we can educate as well. So you have to ask them to know. And then we're going to talk about generalizations and stereotypes, cultural practices, and how it's viewed around the world, and think about care plan. So generalizations are often used to express observations about a culture or shared characteristic or pattern. It's important to really recognize these observation note tendency. They're not universally applicable, and you should be careful with them, right? And stereotypes, on the other hand, are really typically oversimplified assumptions about groups or individuals. They can result in prejudice, bias, or limited knowledge, and unfair assumptions. So, nurses, when we think about understanding this cultural competence, we want to avoid stereotyping, minimize misunderstanding and negative interactions, communicate, ask your patient what do they need, what do they want, is there any barriers to understanding their care, right? So when we think about worldview, this has a big approach to care. We need to be aware of different ways of approaching healthcare. So whether it be in the UK or Canada or all over the world, we need to be able to think of how people have interacted with healthcare systems before. How is that influencing their interaction currently, right? And are there some nonverbal, verbal communication that is happening that, again, we need to be aware of because it may cause misunderstanding if it's conveying an emotion that we're not perceiving correctly. And verbal styles may range from direct to indirect, and this can be, again, a big influence on the topic. So if you're doing STI education or you're in a community and you're looking at diabetes, right? You have to think about the culture you're providing it and the way that they want this communicated to them. So open and respectful always. And now we're going to talk about space. So how are we communicating? What are we doing with our body, right? And then what is this sharing about space? Some people may or not may be comfortable at a certain range of space. So we want to be mindful of that when we're, again, doing our interventions. So we think intimate space where within 18 inches, personal space is 18 inches to 3 feet, social space that 3 to 6 feet. After COVID-19, we're all very aware of that 6 feet, and public space greater than 6 feet. So you're presenting. Again, you want to think about people's culture in relationship to how closely they're going to be when you're doing your interventions. So social organization, this refers to the ways in which groups organize themselves. So you should be familiar with this. Social organization, we can think of it in media, right? We could think about it in groups even within the university. We can think about it within family structure and these cultural bonds. And now we want to use all of those ways of thinking of social organization and then say, okay, how can we now position ourselves as public health nurses to impact change on a policy, healthcare, education level in these different groups? Time perception, right? So this is views of the time clock and social time really are different globally. If you've ever been to Tanzania and you're going to meet someone for coffee, they may be there 3 hours later. So the construct of time in the United States is very different than those in different countries. So when you're out in the community, you need to ask them what their view of time is and planning. If you're going to plan a big intervention and then people are going to be there, they want to start right on time. Are they going to be coming in late? You have to be able to know that when you're planning and working with communities. In terms of environmental control, so we're thinking about individuals' control over both nature and environmental factors. They can feel this loss of control if something in their environment is starting to happen that could be negative, right? So we think of natural disasters, that could be a loss of control kind of externally. Internally, maybe it's maybe someone has died, right? And we have that grief, that loss of control. So we want to think about, again, always culture in terms of how people are responding, because maybe that disease chronic disease And again, I'll use diabetes, could be that sense of loss of control for someone. And they may not be able to hear any of the education or planning that you're giving them until they feel that control coming back. And so just being aware of that and giving space for that so that we can tailor interventions in the most impactful way. We think of nutrition, this is very culturally relevant. It's complex, multifaceted. It can have social, symbolic meaning, right? Are we celebrating, having desserts? All of this is impacted by geography, climate, region, history, religion, really influences food. So some cultures believe that certain non-food items have medicinal or healing properties. So again, here we're looking at just a coping mechanism, thinking about different cultural practices, things that you may or may not be comfortable with, being aware of how that's going to play into health. So what is the role of culture in disease? First, we think of management. So the role is significant. Again, multifaceted. Culture influences how individuals perceive, experience, and respond to illness, health, and treatment. So we have to know the culture first and foremost in order to be effective as a healthcare professional and then provide education and planning for treatment and care. So here, this is just showing this illustration, this web of causation. These are the many cultural factors that are influencing health belief and treatment planned. So as a nurse, you're positioned to help support this transition back into community or community to get to primary care or researching topics, working within the county, so many different roles, right? And it's very complex. So as the nurse, we're thinking of policy, education, care management, discharge planning, and we can think of it, all of this, if we look at like type 2 diabetes, right, is influenced by family and social support, language and communication, religious beliefs, right? So if someone has just gotten a diagnosis and it's during a particular time of year, that could be very hard, part of their family. Also the stigma and mental health associated with it. And so we want to take all of these things into consideration when we're with our patients and when we're in the communities. The nice thing about being in the community is you have a little bit more time to really sit there with them and understand this than sometimes we would in an acute care setting. So now we're going to think about cultural influences on health outcomes. We've sort of been doing this all along and really try to promote this understanding. The first part of this was just awareness, right? Are we aware of it? Or now are we aware of it to the extent that we need to be? And then also thinking about its implication to health outcomes. So as you guys are familiar with these social determinants of health, right, you should be able to now say this. These are the conditions in which people are born, grow, live, work, and age. These include socioeconomic status, education, immigration status, language, neighborhood, physical environment, employment, social support networks, access to care. And it's all shaped by health beliefs, behaviors, and practices. We think about how language can intersect with these other social determinants of health. And then we think of things like race, gender, socioeconomic status that are also influencing it. We need to be aware of any misunderstandings that may be a barrier to a nurse's ability to assist patients and individuals in the communities and acute care settings. First and foremost, have to be aware of our own assumptions in order to then be effective in putting patients first. We want to avoid these misunderstandings by really talking to people, asking them what their health belief is. If you're seeing that there is a resistance to an intervention, instead of calling someone just non-compliant, think about it. Ask them, like, is there something you are trying to celebrate with your family? Is there like a small modification we can make? Or is this not going to work for you? So it's part of this shared decision making that we want to bring in and think about when we're out there in the communities. And if we're just going to be very prescriptive and say, here's your discharge, or here's what you need to do in the community, here's where you need to shop, without thinking about the fact that they may not go to a grocery store that carries that because they go to one that represents their culture, right? Then the intervention and education is never going to work. So we have to be able to ask questions. Where are you going to the grocery store? How do you get there? Who do you cook for? Who do you cook with? What's your day like? Then we can start, recommending some interventions that will be effective long term. Thank you.